Well, hi, everybody. Welcome to CCO Club Webinar number 20. And I'm Jo-Anne Sheehan, and I will be answering questions today on obstetrics. There seems to be a lot of confusion with multiple births and what's considered high risk and what you can and cannot bill for. Now, I have done a presentation on this before, so I touched a little bit on that, but this is really all new type of coding scenarios. The focus is primarily on the CPT manual. There is some reference to the ICD-10 codes. However, this is more on the CPT coding for obstetrical billing. So the question basically is to please provide examples of obstetrical procedures and coding, and there are many scenarios and it gets confusing. And I know that one of our club members had a question last week concerning billing for postpartum care in a group. And so I did a lot of research, talked to insurance companies just to make sure I had it all covered. So we will be touching on that today. So first of all, general information. Obstetrical and maternity care is the care women receive during pregnancy, labor, and delivery, as well as the postpartum period. And every patient situation is different. You have to know their insurance plan and benefits, and you need to ask yourself, has this patient been seen by another OBGYN practice for this pregnancy? If so, at what point are you, as the coder and biller, going to begin coding for services? Now, for many of you, if you're coding for obstetrics, you may not run into too many situations where the services are split up. For me, over the years, I've done a lot of coding for obstetrical on Martha's Vineyard in Nantucket, and the scenarios changed all the time simply because patients went there for vacations, or else they started where they lived there and then they moved off island and so forth. A lot of transients, and there were always unique situations with that. In fact, a lot of times on the island, the family practitioner would see the patient for all of the obstetrical care, including the vaginal delivery. And if a complication arose where the baby failed to progress, then a general surgeon would come in and do, say, the C-section only. And so it was very interesting coding for the obstetrical departments on those islands. Is very different than the mainland. Now, the office should always use electronic technology to verify effective dates and the patient co-payments before commencing services. Member liability may include, but not be limited to, co-payments, deductibles, co-insurance, and they will be applied depending upon the member's benefit plan. Recently, I spoke to an office manager at an OBGYN group, and they said that they have the patient sign a form saying that they have a large deductible, and that the office actually will collect like $500 or $1,000 up front before the antepartum care even begins. And then once the baby's delivered and the insurance processes, if there's any additional funds, the patient would be billed, or if there was a reimbursement, the patient would be paid back. I'm not a fan of that, but I guess it's becoming more and more familiar and common in practices. There may be certain services that require prior authorization or referrals, particularly if there are problems, as the obstetrician may, he may actually have to provide a referral or get a referral from the PCP if he has to refer his patient out to see a specialist for whatever reason. So you want to refer to the member's subscriber certificate for more information and authorization requirements by product. Generally, you don't need a referral to see an OBGYN. You could just go in, but you just have to be careful, again, of any services that were done prior to. Now, payers typically reimburse the professional obstetrical and maternity care at a single all-inclusive global contract rate when all the components of the global services are provided by the same physician or the same group. And in that global delivery is antepartum, the labor and delivery, as well as postpartum. And the global deliveries would be consistent with the CPT guidelines. Now, in antepartum care, which is part of the delivery, the prenatal history and physical exams takes place. And in parentheses, you'll see here, initial and subsequent. Well, the initial is typically the visit that you can bill for right away. That's the confirmation of the pregnancy. And, you know, the doctor does the history and physical exam on you. And then the subsequent visit, which would be your initial antepartum care. So for the first initial visit, where you have confirmation of the pregnancy, you want to make sure you collect that copayment. At that time, there'll be recordings of weight, blood pressure, fetal heart tones. There'll be routine chemical urinalysis. And the way it's broken up is that for the first 28 weeks of gestation, the mom-to-be will go once a month to see the obstetrician. And then from 29 weeks up to 36 weeks, it's twice a month. And then once we get past the 36 weeks, the mom usually goes once a week until delivery. And the delivery services are admission to the hospital, history and physical exam, management of uncomplicated labor, and then as an example, like vaginal delivery with or without forceps, with or without episiotomy, or cesarean delivery, including the delivery of the placenta. And here when we're talking about delivery, you know, in the global delivery, management of uncomplicated labor, this is where you have to know as coders what exactly is considered complicated and uncomplicated. For example, when I first started coding for obstetrics, and I would read pages and pages of notes from when the woman was admitted, and so many things seemed like they were complications. And I realized through experience that, in fact, they weren't. So, for example, a lot of women, a high percentage of women who have epidurals during labor will experience nausea, intense vomiting, their blood pressure can drop. They may need oxygen because they're not breathing properly. And it may seem like really high risk, but yet that is a very common factor for people that have epidural anesthesia. Now, the postpartum care, which was the subject that was raised last week, is the hospital visits and outpatient visits for 6 weeks following delivery. You do not bill the insurance for an asymptomatic patient. It is bundled into the global surgery. So basically, unless the patient has a significant problem after the delivery, you are not going to bill insurance for the postpartum care. It's just all falls under the global CPT code, say 59400 for vaginal delivery. But I'll get into that more as we move forward. Now, there are certain services that are payable in addition to, you know, the global billing. Some of it the doctor may do, some of it may be sent out. And for example, the CBC, the complete blood count with differential, the blood group, determining the mom's blood type, AB, or O, or the RH, the rhesus factor, lacks or has too much protein in the blood cells, or an antibody screen, which is a type and screen individual's blood for antibodies whenever a blood transfusion is anticipated. Rubella, very dangerous. A baby can be affected by it. Syphilis serology, hepatitis B surface antigen, HIV antigen with HIV-1 and HIV-2 antibodies, and that's to determine if the patient is infected with the HIV virus. Those are all things that can be billed separately if, in fact, the doctor does any of those in the office. It may, in fact, only include a blood draw and then pathology bills, whatever, but regardless, that is not part of the global. Additional separate services would be the antenatal inpatient medical care for medical complications of pregnancy. And again, we'll be going through that. The RHOD immune globulin, the RHIG human, the cost of the drug, other therapeutic injections, mandated pap smears, amniocentesis. And here's a picture of the amniocentesis where fluid is drawn out of the uterus to determine whether or not the baby has any abnormalities. Fetal non-stress tests. It checks the fetal heart rate. For example, my daughter, my oldest daughter, when she was pregnant with her first, her son only had 2 vessels in his umbilical cord, and that could result in a lot of problems in terms of the heart not developing or the liver and just other issues. And towards the end of her pregnancy, she went in every week for a fetal non-stress test in order to see if all the organs were functioning properly. And thank goodness, you know, he was born healthy and he's still healthy. But there's 75% of babies with the 2-vessel cord are okay, but there are some that are not. And so if that is done, that would be billed separately. Also, a fetal blood scalp sampling. This is used during labor to determine if fetal oxygenation is sufficient. And then I know I have seen babies that have had that, and when they're born, they have, it's like a little crochet hook into the scalp as they're, you know, doing this. And it's really interesting, you know, what it looks like, but it's definitely effective. So that's, again, all separately billable. Now, also, which you can bill separately, is the external, internal, cephalic, or pelvic version techniques. Now, what does that mean? External is the manual rotation of the fetus from the breech to cephalic presentation via external manipulation of the maternal abdomen. And cephalic is head first, which is what we're shooting for when we're pregnant. Internal is changing the position, for example, of the second twin after delivery of the first vaginal manipulation. And then we have the cephalic external version, and it's a process by which a breech baby can sometimes be turned from the buttocks or foot first to the head first, and that's done internally on the cephalic external version. So this can be billed in addition to a delivery code. So for example, if you had a vaginal delivery global for the 59400 with an approximate reimbursement rate of $2,158, you could also bill a 59412, which is about $108. And according to the National Correct Coding Initiative, there are no modifiers needed. You can add these two together, build them out together, and you'll get paid for them. We also can bill separately for the hemoglobin A1C, which is the OB glucose challenge test and the glucose loading test. The cervical cerclage, when medically necessary for an incompetent cervix, and that CPT code would be 59320, which is the cerclage of the cervix during pregnancy, vaginal. And that reimbursement is approximately $175. And you can see the diagram here where we have the placenta and the uterus. Here's the little baby. And this is actually more common than I ever realized. And this is what it looks like, a real picture. But what it does is it clamps up and closes the cervix right here, so that way the baby can't fall out. And that is something that, you know, would be done, say, in the office or an outpatient or whatever, and that would be billable during the, during the antepartum services. Also separately billable is the maternal serum alpha fetoprotein. And this is to check for babies with neural tube defects. I know that this particular test, I know so many women who have had this test and went through 9 months of pregnancy thinking that their child had spina bifida and their children were born perfectly fine. So, but it is a payable separate service, and if you opt for it, or you allow your obstetrician to do it, that he can bill for that. Now, one complete obstetric ultrasound per member per routine pregnancy can be billed as a payable separate service, and a coder should really check the medical policies per payer. I have had incidences where I billed more than one ultrasound, and usually it's because it's multiple gestations, or there are other issues concerned, with the patient. Medically necessary lab tests for medical complications such as heart disease or diabetes. Separate components of obstetrical care when provided by different provider groups. And basically that just means, if one provider group did antepartum, another group did the delivery, and then another group did the postpartum or whatever, all of those are unbundled, and they can be unbundled because different providers are giving the service. Services billed with the appropriate CPT code by providers who are giving only antepartum, delivery, or postpartum, not the total global obstetrical package. So I will be showing you different examples of that as we move forward to give you an idea of the various coding scenarios. Now, multiple births based on one global obstetrical allowance. Additional reimbursement is made only when the delivery of each baby is by different means and reported with the appropriate delivery only code. So, for example, let's say that the mom delivered vaginally and everything fell under the global period, and we use the 59400 after the delivery of the baby. And then the second code we would be using is the 59409, which is the vaginal delivery only. And it would only be one unit if it was twins. So this represents the first baby. This represents the second baby. Now, if they were triplets, you would continue with this, but you would indicate 2 units. So for each additional baby, and you would adjust the billable amount according to how many babies. But this is the global here. This is just for the vaginal delivery only. And I cannot stress enough how payers will vary on how they want this done. In fact, I had studied a few years ago an AAPC presentation on obstetrics and gynecology, and the information that they got from the payers when they did their presentation indicated it should be a modifier 51. Now, I thought that was kind of interesting. However, I'm on the East Coast, and I have never used any other modifier except 59, because across the board, that is what my payers wanted. Now, non-reimbursable services, these are services included in the global obstetrical package by the same provider reporting the global code. So services included in that global package by the same doctor reporting the global code. So you're not going to bill for office visits separately. You're just going to bill the delivery code. Additional payment for the delivery of more than one baby when babies are delivered via the same methodology. Now, if you did deliver twins vaginally and it was a global, you would not do 59400 and 59400. As I just told you, this one would be the complete package, antepartum, labor, delivery, postpartum, and then it would be 59409 vaginal delivery only for each additional with the modifier 59. So this would not be the correct way. Services provided by a covering physician for the physician or group billing the global OB service. So if there are any services by the covering physician or by the doctor in the group, even if it's separate, it's all part of the global. And standby services, this one you want to make sure. I have never been paid for standby services by any payer in the 35 plus years that I have been coding. However, that doesn't mean that you don't have a payer, that will pay it. So you want to make sure. And I can say the one thing that I really love about obstetrical billing is that you can go into all the payers that you're familiar with and that you work with, and they have a few pages just on obstetrics and what's accepted and what modifiers to use and so forth. And it's really, really comprehensive, and not many specialties get that. So if you're doing billing and coding for the obstetrics, definitely set up a folder on your desktop and just put all your payers in there so that if you need to research something, you'll know what to do. So just know that though some services like standby may not be reimbursable, you may have an insurance carrier that does reimburse. Now, there are very specific billing guidelines. As I said, don't separately report services that are included in the global package. You submit one claim after delivery, and this will be for all the antepartum delivery and postpartum services. If that's like a very standard normal delivery, you will bill separately for tests and services as they occur, if you're allowed to. Separately allow services billed after the delivery date could deny if you're exceeding the file limit based on the date of service. So if you're billing something, say like the cerclage of the cervix, do it then. Don't wait until after the delivery of the baby, because as we all know, the majority of our payers are on a 90-day filing limit, so you don't want to miss out on that. Now, when we bill multiple births and delivered by different methodology is the following. You want to bill the global CPT. So for example, for the cesarean delivery, the 59510 is the routine obstetric care, including antepartum care, cesarean delivery, and postpartum care. And that's approximately $2,600 reimbursement. And that's at the low end. 59618 is routine obstetric care, including antepartum care, cesarean delivery, postpartum care, following an attempted vaginal delivery after a previous cesarean delivery. And it's only a $30 difference. But this, no matter what, you would be using one unit of service. Now, when we're billing for just the global on the vaginal, the 59400, as I said, if you bill the 59409, that's the vaginal delivery only. That's either, that's all that the doctor does, or it's for the second, third baby. And that is approximately $905. And then the 59612 is vaginal delivery only, but after a previous C-section with or without a episiotomy and or forceps. And that one's a little more on the reimbursable for, and it's $1,020. So when you see the vaginal delivery only with or without postpartum care, you see the incision may be made to aid in the delivery. Most doctors don't do episiotomies anymore, but sometimes it's just not something that can be helped. And here would be where the medial-lateral incision would be. And then the vaginal delivery only after a previous C-section. A baby is delivered vaginally from a patient who has previously undergone a C-section, and without 59612 or with postpartum care 59614. So just to show you visually, the 59400, as I said before, would be the vaginal delivery global one baby. The 59409 would be modifier 59, vaginal delivery only, and that would be for the second baby, and use this code once after the 59400, but you would increase the units for each additional baby, and you would also change your billing amount. Now, if you did the 59610, which is vaginal delivery after a previous C-section, which is approximately $2,500, then you would do 59612 with a modifier 59, vaginal delivery only after a previous C-section, and for every baby, you would increase the units. All right, so it's the same whether it's vaginal or vaginal after a previous C-section. Now, is a fetal non-stress test usually performed in the ER? The OB doctor saw the patient in the ER and the patient was not admitted. Can you bill like a 99283 with modifier 25 and a fetal non-stress code in this situation? The ER doctor did not even examine the patient. So you're saying that the OB doctor saw the patient? Yes, absolutely. If that is how he made the determination that he needed to do the non-fetal stress test, you would definitely add the modifier 25 and then bill for it. But you just have to make sure that you're using an appropriate diagnosis code, not your typical encounter for pregnancy or whatever. It has to be a reason, because even though he is the obstetrician, the service is being provided outside, and there's usually a problem associated with it. So let's see, from social media, there is confusion in my class with modifier 59 and modifier 51. Can we use them on the same CPT code? Actually, I have certain procedures where I can. I do use 59 and 51, but in all honesty, a lot of the procedures, especially with Medicare, you don't have to add the modifier 51. It's just automatically assigned if it's part of the same family of coding. But if you did add the 59 and the 51, I would sequence it as 59 first and 51 second. It's not going to hurt you. So definitely you can do that. Now, as far as this, it is always an O code as the diagnosis. Well, if it's an O code, there are so many O codes with obstetrics. It just there has to be a reason. If he says to the patient, meet me at the ER and I'm going to do a non-fetal stress test, then you wouldn't bill for the emergency room. But if the patient comes in and then the obstetrician goes in and makes the decision to do it, then I would add the modifier 25. It's all relative. But usually there has to be a problem. And so if it's an O code, say a lot of times the patient has abdominal pain, and definitely the chief complaint would be abdominal pain. And I know that based on the ICD-10 guidelines and how you would code it, it might be that you're just using abdominal pain and then using an O code after the fact. I just, off the top of my head, I would have to look at the guidelines because they're very, very specific on how you do things. But abdominal pain absolutely is a reason for being seen in the emergency room and why the patient would have that done. The only thing I'm thinking is that because this is in the emergency room and it's part of the antepartum care before the labor and delivery, I'm thinking that it might actually, you might have to use modifier 24 to indicate that it's not related to your global obstetrics. You might even have to, or do 24, 25 or something like that. And again, it would be payer by payer, but if you were doing the visit, you would definitely have to do the modifier 25, but you have to also let the insurance know that this is not part of the global, otherwise you won't get paid. So the complaint would definitely have to be abdominal pain. And off the top of my head, I don't know if there is a obstetrical code that's associated with that. So we'd have to research it, but definitely that's a significant reason why the doctor did it. Now, we bill global delivery codes if care begins on or before the 25th week, and both delivery and postpartum care is provided. You bill antepartum only, delivery only, and postpartum only services for pregnancy loss, change, or termination of insurance coverage, or change in the provider. You bill delivery only services or delivery including postpartum care when antepartum care has been rendered by a different provider or a different group. Hopefully that makes sense. And then these are a lot of the specific codes that we would use for obstetrics, starting with the 59000, the amniocentesis, and the fetal contraction stress test, the 59025 fetal non-stress test, the fetal scalp sampling, the cerclage during pregnancy. Then we have the global vaginal, the vaginal delivery only, and then the 594 vaginal delivery only, including the postpartum. We have the external cephalic version with or without chocolysis. Antepartum care limited to 1 to 3 visits. So if you the patient or the patient sees the doctor one time and then moves on, then you would just bill the E&M code. So for example, my daughter is having her first antepartum visit with the obstetrician in Boston. However, she's going May 29th, and she's moving to North Carolina June 3rd. And so that's the doctor, the obstetrician would only bill for that one E&M code and count for pregnancy in the antepartum. And then everything else would, fall on the new group or new doctor that she finds. The 59425, Antepartum care only 4 to 6 visits, but you're not going to, in units, you're only going to use 1 unit. So it doesn't matter if the patient was seen 4 times or 6 times, you're not going to put 4 units there. Let's see, another question. I am seeing a lot of OB coding where the weeks of gestation is coded as unspecified. Is it necessary to code unspecified weeks of gestation if the weeks are not known? The OB coder where I work does not always code the weeks of gestation. It is part of the coding, the global, it is part of the coding for obstetrics during the delivery, or even if there's a problem beforehand, it is supposed to be indicated, and it should be in the documentation, or she should be looking in the note. Unspecified will always get paid, but my concern has always been, as we transition into quality reporting and specificity, that ultimately any unspecified codes are going to come around and kind of bite you in the back. It's ultimately reimbursements will be impacted by that. So I think it's worth it to have either the doctor indicate it or look into the electronic medical record and see at what week the patient's at. There's usually a chart as to, especially in a group, what doctor or midwife or whoever saw the patient at that time, and it should indicate what weeks. I've never seen any obstetrical documentation where that wasn't indicated, but I'm not sure. So I've seen modifier 26 used sometimes on fetal non-stress test codes. When is modifier 26 actually needed with this code? Modifier 26 is the interpretation. If you're in a facility and they're doing that, they own the equipment and they're interpreting it, then that is a global, and you would not use the modifier TC for technical component and 26 for the interpretation. It's if the stress test is done in the hospital and they bill for the technical component, and then the doctor actually gets the reading and interprets it, then that's where you would add the modifier 26. That's just saying that the physician does not own the equipment. Let's see. Now the 59426 is the antepartum care only 7 or more visits, and again, only 1 unit, not 7 or more. The 59430, which we're going to talk about a lot today because Whitney had asked about postpartum care, but if we're only billing for postpartum care, again, that's only 1 count, even if the patient is seen by the doctor more than once within that 6-week period. The 59510 is the routine obstetric care global for cesarean. You don't break it down by individual components. If it's just the C-section only, then you would bill this in addition to the global C-section code when reporting multiple deliveries. And I do want to stress here that you should try to know what your payers do. I know for a fact that because of my situation, coding, you know, Martha's Vineyard and Nantucket, a lot of times the family practitioner will take the mom-to-be right up to labor and delivery, and then something happens where the baby fails to progress or something happens, and he will bill to a certain point, and then the general surgeon will bill for the C-section only. And I know our Massachusetts Medicaid rules don't get it at all, but we follow their guidelines, and believe me, it took months and months to figure out how they wanted it done. And in fact, we had to split up, like to the Medicaid, we billed certain codes, and then the C-section only had to go to a third-party administrator. So if you run into problems, make sure you call and find out, because it's not unusual for some of these random payers to have different rules. The 59515 is a cesarean delivery only, including the postpartum care. And of course, the 59610 is the routine obstetrics, including antepartum, vaginal delivery, and postpartum after a previous C-section. And then that's the vaginal delivery only after a previous C-section. And then 59614 is the vaginal delivery only after a previous C-section, and so forth. So we have all of these codes here, and you just want to make sure that you follow accordingly and know what's what. And if you have 5 doctors in an obstetrical group, they're still going to fall under the global. Absolutely, unless there is a problem. So a lot of times the way doctors will reimburse themselves is based on the internal accounting system. So if Dr. A does 4 antepartums and does the postpartum, that'll all be documented, you know, in the medical record. But then Dr. B delivers the baby, then he may get more money if that's how the practice works. I don't know, or else they just take that money and divide it by 5 providers. It's all relative to what they want to do. But it is important to make sure that if it's all part of a group, that you follow the guidelines. And if there's anything that's high risk or extenuating circumstances, bill it as you go so you don't lose out on the money. Now, most likely in the obstetrics, you're not going to be billing for ultrasounds, you know, 76801, 76802 for the first trimester, or 76805 or 76810 after the first trimester. So I did diagnostic radiology, and I billed for ultrasounds for pregnancy, and it was always that I billed for the technical component for the lab, and then a radiology group billed for the professional component with the modifier 26. And I used the modifier TC because I coded for the actual taking of the ultrasound. Then we have the blood panels, the obstetrical panel including HIV and so forth. If both panels codes are billed together, one will be reimbursed. And then we have the antibodies, Zika virus, and all of that, and that's separately reimbursed as well. Most likely, if you're not sent to a lab to have the blood drawn and the tests done, the doctor may in fact draw the blood or do whatever in the office, and you could bill for a blood draw. They may do this, I don't know, but typically these are pathology codes. Now, if we do 96372, which is a therapeutic, prophylactic, or diagnostic injection that's intramuscular, that is separately reimbursed from the global OB payment. And you would use that's the administration, and for the ROGAM. And the ROGAM HCPCS is J2790, and here you have the description of 300 micrograms or 1,500 international units, and don't forget your national drug code to go along with that. And the ROGAM is a sterilized solution made from human blood used to prevent an immune response to Rh-positive blood in people with an Rh-negative blood type. ROGAM may also be used in the treatment of immune thrombocytopenic purpura. So this can be billed at any given time during the obstetrics. That is definitely separately billable. I know I see another question. Let's see, most of our OB patients have TennCare Medicaid, so that may account for some things being coded differently. Absolutely. I know for a fact that like I said, with our Medicaid provider, it was definitely broken up. Different insurance companies did different things, and it was to get that information from Medicaid. It was like pulling teeth. It was awful. And when we finally got someone to work with us, it was easy. And you would be surprised how many women on the island, especially young girls, that start out with the vaginal and end up having a C-section. So it was something that happened a lot. So we got our experience with it. If there was more than one baby and you use the code 59612 with modifier 59, would you repeat that modifier with each separate code or just the unit? You would use that code once and with modifier 59, but you change the units. So you do your first baby, the global code, and then you would use the 59612 with the modifier 59. So say there were 2 additional babies, that mom had triplets, you would do the 59612 add the modifier 59 and change it to 2 units, meaning 2 additional babies. And say if it was $900 you billed for 1 additional baby, double that to $1,800. Don't do per line. It's only 1 report, but you just change the units, and those units represent how many babies. Does that make sense? Hopefully. Okay. Now, for billing purposes, the obstetrical period begins on the date of the initial visit in which pregnancy was confirmed and extends through the end of the postpartum period. Typically, it's 56 days after a vaginal delivery and 90 days after a C-section. Now, the global obstetric code should be billed whenever one doctor or a number of doctors in the same group provide all the components of the patient's obstetrical care. So that's including 4 or more antepartum visits, the labor and delivery, as well as the postpartum care. So if you're doing a vaginal delivery in the group, even if 5 doctors, and that's very, very common, see the patient. So the patient's familiar with all the doctors in the event that one of the covering doctors is going to deliver a baby. So it's still global. You don't break it up. I mean, I have 3 children and I had 1 obstetrician, but out of my 3, my obstetrician only delivered 1. My other 2 were delivered by other doctors, but I only got 1. I only saw 1 bill go out for the group. It wasn't per doctor. Because it was a group billing global. Now, the number of antepartum visits may vary from patient to patient. However, if global OB care, more than the 3 antepartum visits, as well as the delivery and postpartum care is provided, all the pregnancy-related visits, excluding inpatient hospital visits for complications of pregnancy, should be billed under the global OB code. Individual evaluation management codes should not be billed to report pregnancy-related E&M visits. And I'll explain that a little further. I mean, it's just if you go in and they check your blood pressure and they do this and that and listen to the heartbeat or whatever, that's part of the global. Now, if it's less than 4 antepartum, as I said, you would bill the 992, 13, 14, 15, depending for those visits. And if not, then so that's like less than 4, so it's 3 or less. The modifier 24.5 should be appended to the E&M codes to indicate that the visits are outside of the global surgery period. And I'm going to give you examples of that as we move forward, because there are things that take place during antepartum care. Say, for example, Whitney, your emergency room visit, that's abdominal pain, and then the non-stress fetal, stress test is done, and that is outside the global period. It's extenuating circumstances. The 59410 is the vaginal delivery only, and that one for global includes the postpartum care. For that code, the 59515 is the C-section, but it includes the postpartum care. There's no antepartum in these. The 59614 is the vaginal delivery only after a previous C-section. That includes the postpartum care as well. Or 59622, the C-section following an attempted vaginal delivery after a previous C-section. And that code also includes the postpartum. So if you have another doctor that's done the antepartum care and then the patient switches out, and another doctor delivers and follows up after the delivery, these are the codes you would use. Now, 4 to 6 antepartum visits, delivery and postpartum, bill the appropriate global surgery code with the 52 modifier appended to indicate reduced services. Now, this is common among a lot of payers, but pay attention to this because you want to be sure that your payer allows it and that you're getting paid appropriately. A lot of times, just adding that modifier 52 because there were less antepartum visits during this period, a lot of times you don't get paid less, but it's just, that is what the requirement is for a lot of insurances. If it's 15 or more visits, And the medically necessary antepartum visits, office or outpatient in the hospital, bill the appropriate OB global code, but append a modifier 22 modifier to indicate increased services. And again, this is, you want documentation attached to this because this will be individual consideration. Individual E&M codes should not be billed for the excess office visits. You want to attach the documentation such as progress notes and or the antepartum flow sheet that clearly describes the medical necessity for each of the additional visits. So, excuse me. When documentation supports the medical necessity of the additional visits, an IME, an individual medical examiner will do like a medical examination of all the information. And if they approve for each additional visit, they'll give you approximately $56. Let's see. Now, inpatient hospital visits for complications of pregnancy may be billed using the appropriate level E&M code. The 25 modifier must be appended to the inpatient hospital E&M. Normal antepartum care, complicated delivery, and postpartum care bill the appropriate OB global code and append the 22, as I said, to indicate the increased services and use documentation. So let's look at, for this global period, an inpatient hospital visit with complications of pregnancy. Just as an example, a pregnant patient was admitted for treatment of a broken leg. The principal diagnosis should be pregnancy because it affected decisions regarding treatment of the leg. Example, administration of certain drugs or sedation. Now, when a delivery occurs, the principal diagnosis should correspond to the main circumstances or complication of the delivery. Signs and symptoms may also pose as coding challenges. Dehydration and excessive vomiting, commonly experienced and documented during pregnancy, might indicate a metabolic syndrome. Elevated blood pressure, severe headaches, and edema could indicate preeclampsia. So if it's not clear in the documentation, you want to query if it's vague, and the physician can point out to a more definitive diagnosis. And that is so important because that allows you to bill for additional visits if necessary, such as the emergency room, or if the patient's brought into observation care or whatever. But again, I'm going to show you some as we move forward. Now, this is one way of billing globally in multiple births, and there are a couple of payers out there that will expect this. Antepartum, delivery, and postpartum care for multiple gestations bill the appropriate OB global code determined by the method of delivery of baby A for one unit, and then append modifier 22. The diagnosis should indicate that there were multiple live births and attach the documentation that describes the method of delivery, vaginal, C-section for each baby or whatever. So there are a couple of payers that want this, but what I'm going to tell you is that do the second way first. And then if you have a problem, then inquire about using modifier 22, because pretty much across the board, it is standard to bill, for example, baby A, the global vaginal delivery at the 59400, and that's reimbursed at 100% of the allowable charge subject to the member's benefits. Then you would add babies B and beyond and file vaginal delivery only, 59409 with the modifier 59 appended. Now, if more than one subsequent baby is delivered, the total number of babies in the 59409 for babies B and beyond should be indicated in the units field. And these are reimbursed at 50% of the allowable charge for each of baby Bs and beyond, again, subject to the member's benefits. So hopefully that makes sense. Now, antepartum, delivery, and postpartum for multiple gestations. This was the original way. Above is the global vaginal delivery. The modifier 22 is increased procedural services. They're not, some insurances do not expect the 59409. The diagnosis codes will indicate the multiple births, and the attached documentation will verify the multiple deliveries. So here we have the date of delivery is May 22nd, 2018. The place of service for this delivery is 21. I'm using my basic global vaginal delivery. 22 modifier is indicated by some payers, and then the diagnosis pointers, which would indicate, you know, the delivery, the gestational period, and how many live births were in it. And the diagnosis codes would be indicating why, you know, there are multiple live births, and that would tell the insurance why you're using modifier 22. But you would have to send documentation. And depending on your payer, sometimes I bill it electronically if I need attachments, wait for it to deny in the system and say they need more information. Then I go in and appeal online and I attach the documentation then. I always worry that if I bill it electronically and then I go in and try to attach it, that it'll get lost in cyberspace. But whatever works if you have good experience with that. Now, there sometimes are assistants at surgery for, you know, the delivery of babies. So antepartum, assisted in delivery and postpartum care, you want to bill the appropriate OB global code and append the modifier AS if it's a non-physician provider, or modifier 80 physician provider if it's appropriate. Now, a lot of the insurance companies are going to also tell you when you use modifier AS, that's indicating that a physician assistant, a nurse practitioner, or a clinical nurse specialist served as the assistant at surgery. Be aware that some payers, when you use modifier AS, they're also going to want you to indicate a second modifier, 80 as an assistant surgery, which means from beginning to end for the whole delivery, say if it's a C-section or whatever, that's like full assistance surgery. Or modifier 81, which is a minimum assistant surgery, which means that he may not do anything, but then the doctor may say, can you just hold this while I do this or whatever, and it's a minimum, and you would attach AS 81. Or modifier 82, which is the physician assistant, nurse practitioner, or certified nurse specialist. And that one's usually someone that's not qualified as a physician. You know what, there is a specific on modifier 82, it's when qualified resident surgeon is not available. Okay, so that's what the modifier 82 is. From my experience and what I've seen in auditing, typically it's either AS or AS and 80, or 81, if it's minimum. But let's look at assistant at surgery for a C-section, just so you have an idea. Assistants at a C-section should be coded using the CPT code 59514, cesarean delivery only, which is approximately $1,020. Now, you're not going to use the 59510, which is the cesarean global, because this assistant at surgery is just helping with the delivery. And the 59510 is the global, which is the antepartum and postpartum, along with the delivery. So you use only code 59510 if you're the doctor who provided both antepartum and postpartum care as well as the C-section. Assistant surgeons usually charge 20 to 25% of the normal fee, but they can also use the same fee schedule as the surgeon. They're not going to get paid the same. Payers will reimburse based on the assistant's allowed amount, which is typically, say. So if the assistant surgeon wanted to bill, you know, for their part in the delivery, they could do the 59514, the assistant at cesarean delivery, modifier AS-80, and instead of putting the $1,020, they could put $255, and the insurance may allow $180, and the patient may owe the difference or whatever. But honestly, if it's all part of the group or whatever, and then there's an assistant, I just use the same fee because you're still going to get paid the low rate. It doesn't matter. The billable, I mean, you could bill $1 million, but if whatever your contracted fee is for the assistant at surgery, that's what you're going to get. So a physician billing for a C-section 59510 for routine obstetrical care, including antepartum care, cesarean delivery, and postpartum care would look like this, which would be May 22nd, place of service 21, that would be the CPT code, and then you would have your diagnosis codes 1, 2, and 3, you know, as far as the delivery, the gestation, and how many live births. The fee, 1 unit. This is global, but we're still using 1 unit, and then the NPI number. Now, if it's an assistant at a cesarean delivery, we're going to be using the 59514, and the payer will typically pay 16% of the allowed. So again, here we have the date of service, the location is the hospital. We're using the 59514. Let's just say if it was a complete assistant surgery physician with the 3 diagnosis codes, the charge is $3,500 and it's 1 unit. And if it was a physician assistant, nurse practitioner, or clinical nurse specialist served as the assistant in surgery, same date of service, the May 22nd, place of service 21, same procedure, 59514, but you would add AS for assistant surgeon, and then 80 if they were there for the complete, you know, the whole time during the cesarean section. Let's see. Now, would an anesthesiologist being at delivery be billed using modifier 80? Would you need something else? Actually, when I am billing, I bill for anesthesia for obstetrics, and I don't use modifier 80 at all. It's depending on the type of anesthesia, whether it's epidural, block, or whatever it is. We use the anesthesia codes and the beginning of when the anesthesiologist starts, you know, when they first go in, check the patient and do whatever, all the way until the end of the delivery. And we put, what do they call it? I say Navy time. I don't think that's the right thing, but you put the amount of time involved and any modifiers that are involved, but never do we use 80 for an assistant at surgery. It would just, whether it's a CRNA or an anesthesiologist or whatever, it's strictly, they have their own set of modifiers. Like, I think for the CRNA, it might be QZ. I could be wrong, but that would be telling, you know, the insurance company that they're a CRNA without physician supervision, and then you would use whatever anesthesiology code for the obstetrics. So no, you would not use modifier 80 at all. So as I said before, for the antepartum care only, 1, 2, and 3 visits, if that's all you're doing, you will bill those, you know, as soon as you know that the patient's moving on. The 3 antepartum visits are performed, and then you bill, you know, the appropriate E&M code if it's an established patient, 99213 or whatever. And if it's 4 to 6 antepartum visits, we have the 59425, 1 unit, not 4 units, 5 units, or 6 units, and the same with 7 to 14. You just use that 59426, 1 unit, not 7 to 14 units. Now, if there's more than 14 antepartum visits due to complications of pregnancy, some insurances will say bill the 59426 and append the 22 modifier to indicate increased services. And then attach the documentation, and then the medical examiner will assess, you know, if you will get paid additional money. Now, when we're billing delivery only, the delivery begins on the date of the initial hospitalization for delivery and extends to the date in which the member is released from the hospital. Hospital care related to the delivery is considered part of the delivery charge and is not considered part of the postpartum care. Now, if a C-section is performed, the reimbursement for the delivery only charge includes payment for the surgical procedure as well as any post-surgical care. So if just the C-section is done, you bill the C-section only, and that includes everything. Now, here we have, again, our own vaginal delivery only, 59409, the C-section only, 59514, the VBAC delivery after a previous C-section, 59612. C-section after attempted VBAC delivery only, 59620. And just to remember, the delivery of multiples, bill the appropriate delivery code determined by the method of delivery of baby A for 1 unit and append the modifier 22, but with documentation. But my recommendation is to add the modifier 59 on the second line with the number of units, meaning number of babies being delivered. Complicated deliveries, you would bill the appropriate delivery code and append modifier 22 and attach documentation. See, the thing is with complications during that whole labor and delivery, a lot of it is driven by the diagnosis codes. There aren't really specific CPT codes for the delivery of the babies. So just to tell you that. Now, for postpartum care, it begins after the patient is discharged from the hospital stay for delivery and extends throughout the postpartum period. Typically, it's 56 days for vaginal delivery, 90 days for C-section. This is a separate procedure, 59430. That means that when you bill 59430, other obstetricians have billed for the antepartum care and or the delivery. The postpartum care only is if that's all the obstetrician is doing. If that doctor is part of the group that's provided antepartum in the delivery and the postpartum, even if the doctor in the group only saw the patient after the baby was delivered, you cannot bill this. This is strictly if it's a different doctor, different group, different tax ID number. So let's look here. This is a Z39.2 is an encounter for a routine postpartum follow-up. This is a separate procedure that, again, is only billed if another obstetrician or obstetricians in a different group did the antepartum and delivery. No antepartum or delivery is included in this code. If these services were performed, it would be considered unbundling. So if you bill the antepartum visits, the delivery, and then the postpartum, that is considered unbundling. So you would be using the Z39.2, and then you would have, like, say, this is postpartum June 15th, 2018, postpartum only, no modifiers needed. One diagnosis that's linked for the diagnosis pointer. $210 is the charge, and it's for that one visit. And again, that's if it's only postpartum care. Now, let's say that the patient is postpartum care only. The patient has peripartum cardiomyopathy. All right, peripartum cardiomyopathy, PPCM, also known as postpartum cardiomyopathy, is an uncommon form of heart failure that happens during the last month of pregnancy or up to 5 months after giving birth. Cardiomyopathy literally means that it's heart muscle disease. So if you're in the group and the doctor is seeing you and they've already billed for the global, you know, the antepartum care and the delivery, but the patient develops this, okay, then this is not a 59430 postpartum care only. You're going to be billing an E&M code, all right? So the first diagnosis code would be 090.3, which is peripartum cardiomyopathy. The guidelines say use additional code Z38.39. I picked that one. 39 weeks gestation of pregnancy. Baby was delivered at 39 weeks. So, and that would be your second diagnosis code. So in this case, the postpartum visit, we would be using place of service 11 for office. Depending on, you know, the exam and history exam and medical decision-making, whatever, or this could be a 99215, or whatever, but you would add a modifier 24 because this is separate from the global. This is a significant problem with the mom. So if the doctor is in that group, you're not doing the 59430 postpartum only. That's a separate procedure bundled into the global. This is part of the group, but it is a separate problem, a complication. So you would be using a modifier 24, and that's just saying that this is out of the global. This should be considered for outside the global period. Okay, now, why would pregnancy be the principal diagnosis when she was admitted for a broken leg? Based on everything that I had read and studied, it's basically telling the insurance company that the patient is pregnant. And then that's telling the insurance company, as well as the doctors working on the patient, that this patient is pregnant and they broke their leg, and they may be, you know, applying a cast or want to give the pain medication. They have to know right off that the patient is pregnant, because they have to know how to treat this broken leg. And it's part of the guidelines. If you really do a lot of research on obstetrics, you will find that that's a very, very common. It's different. It's a different type of a coding. How do I say, like the HIV, usually if you have an HIV related problem, you know, like a broken leg, you would code for the broken leg first and then say HIV. But if you were pregnant, you would find the pregnancy code associated with the HIV. So this is just saying that this patient is pregnant, and then the broken leg. And it is because if you think about it logically, and that's what I try to do a lot of times when I don't get something, it's like, yeah, it's like this is reflecting, it's telling a story. And yes, this patient is pregnant and she broke her leg. So if you're billing, say, an emergency room visit with the decision to like manipulate the leg or do whatever, then you want to indicate that the leg's broken and link that link to the procedure or whatever for the broken leg. But it's also part of the medical record so that the doctors know how to treat the patient. And honestly, the only way that a pregnancy code is not principal diagnosis is when the patient is HIV. Is that correct? Yes, there are codes, if I'm not mistaken, there are codes that are obstetrical that incorporate the HIV, but pretty much, let's see, pretty much when the patient has HIV, it really does impact how you treat the patient in a number of different ways, so that you would definitely be coding the HIV first and then any other pregnancy codes. But honestly, right off the top of my head, I don't know if there are any O codes or any codes in there that incorporate pregnancy with HIV. If not, definitely I would do the HIV first and then the pregnancy. It's usually if it's something that's like this example, this guideline, where the leg is broken, something like that. I hope that makes sense. I'm going to have to look up that one though, because that's going to bother me now. So, because I know with pregnancy and HIV, I was focused more on the CPT codes, but I'll find out and share that next time. Now, for the postpartum care only, if a patient develops complications of pregnancy or the provider treats the patient for an unrelated problem, these visits are excluded from the maternity global package, as I told you, so they can be reported separately. Use the modifier 24, unrelated E&M service by the same physician during the global period. To all the E&M services that address the pregnancy complications or unrelated issues. Modifier 24 is needed to alert the carrier that the E&M service is unrelated to the global package. That's why I think that if you have an unrelated office visit or emergency room visit, and it's part of the global, that you would have to indicate that it's unrelated to the global, but it's also, you require a modifier. So 25, you know, if it's a procedure, so you would have to use both. Now, when a provider performs delivery and postpartum care, but didn't perform the antepartum care, then you're doing the delivery and the postpartum care. And we've already gone through these codes before, the 59410, 59515, 59614, and 59622. But let's look at a pregnancy complication in observation. And this happens a lot, the patient has what's called preterm labor, and that means that labor is started more than 3 weeks prior to the patient's due date. So on day 1, the patient is admitted for observation care, and the physician performs a comprehensive history and exam plus a moderate medical decision-making, which is CPT code 99219. Now, day 2, the patient's condition has improved, and the physician discharges the patient 99217. Modifier 24 would be appended to these codes because it's unrelated to the global maternity package. So the patient has preterm labor, and the diagnosis code would be 060.00. The additional code used for the gestation period of 37 weeks. So let's assume that she went into observation at 37-week period. So we would be using the gestational period as the second diagnosis. We would use the 99219-24 and the 99217 discharge with modifier 24. And it would look like this. So we have the 06000 for the preterm labor, 37 weeks gestation at the time of observation. So let's say it was April 1st, and we did the 99219 modifier 24, and we're linking the 1 and the 2. Okay, here, 1 and 2. And then the 30 is for the outpatient. Observation can be in a hospital setting, it could be in the emergency room, it could be in a corridor of the hospital. But the observation codes, for 2018, they changed the wording, and they put in the description that the observation codes would be considered outpatient services. So you would be using a place of service code 30. And that would be the initial, and that would be the discharge. And basically that would be what you would be using. Okay, so that's just one example. A lot of times patients will go into the hospital and the doctor's checking and they put them in observation, and then the doctor may send them home, and it's just because they think the patient's in labor or they're watching her or whatever. But if they end up admitting the patient, but say that they did a preterm labor or whatever, or there was some other complication, you could bill the observation, and then if they admitted the patient, you wouldn't bill the admission code at that point. You would just bill whatever was appropriate. If it was the global delivery, you know, with the antepartum delivery and postpartum or whatever the doctor was doing. Some of the medical complications that would change the way, you know, you use the E&M services with the modifier 24. It could be cardiac problems, neurological problems, diabetes, hypertension, toxemia, hyperemesis, preterm labor, premature rupture of the membranes. Services should be coded separately when there are complications and you're using CPT codes from the surgery section. So for example, you're pregnant and you have an emergency appendectomy or a hernia operation, or there's a problem and you have to have an ovarian cyst removed or a Bartholin cyst. I know a young girl years ago that when she was diagnosed as being pregnant, it was then that they found out that she had breast cancer. So, I mean, there were tons of E&M services involving her breast cancer and her double mastectomy and her reconstruction. And it was just one of the most complicated deliveries, and everything was separate because this poor girl was dealing with the chemotherapy and everything else. But these things do happen, and you just have to look at it logically and say, okay, do I need modifier 24? Do I use 59? Do I use modifier 22 with complications, you know, and documentation? And the guidelines will definitely help you. Now, let's look at obstetrical care in 2 different doctors. Relocation of a patient. Physician A treats a patient in Overland Park, Kansas, but then the patient moves away. Physician B, who practices in Chapel Hill, North Carolina, begins treating the patient who has recently relocated. Physician A, who's in Kansas, only provided 4 antepartum visits. But physician B provided 8 antepartum visits, as well as performed the delivery and postpartum care. So we're talking about obstetrical care and 2 different physicians. And this is more common than you think. All right, so here we have physician A treats the patient in Kansas and provides 4 antepartum visits. So as described by ACOG and the AMA, we have the antepartum care only codes 59425 and 59426, and they would be reported as described below. Excluding the confirmatory visit that may be reported covered. Physician A treats the patient in Kansas and only had 4 antepartum